All right. With that, I think I'm going to introduce Dr. Bowlus to the stage to give us a talk on the treatment landscape for PSC. Dr. Bowlus is, as you know, internationally renowned and has dedicated his life for the care of patients with PSC, PBC, and autoimmune hepatitis with just numerous publications and leadership roles. He is a Lena Van Heen Professor and Chief of Medicine, Chief of GI and Hepatology at UC Davis. He has active research bridging from basic science to clinical aspects of PBC, PSC, and autoimmune hepatitis. He is a founding member and a member of the steering committee of the International PSC Study Group, and also a lead and founder of the North America Consortium for Autoimmune Liver Diseases. Dr. Bowlus is very dedicated and engaged in advocacy, patient advocacy, and he is the co-chair of the Scientific Advisory Committee of PSC Partners. And I have to say, he is the reason why I am involved in PSC and patient care. He's been my mentor since I was a fellow. And thank you so much for everything. But welcome. Thank you.
Well, thank you, Kiddis. It actually was when you were a resident, remember? You were in my clinic and came over? We go back a ways. We go back a ways. And thank you, Kiddis, and the organizers for setting this up. This is an amazing event, and I'm really happy to be here and participate. I also want to say, you know, your PSC Partners are going to put this on in LA, Chicago, New York also, I hear. They can't compare with what you have here in Northern California in terms of 4 large academic medical centers that are not only experts in liver disease, but have dedicated people with expertise in PSC. I mean, whether it's EPMC, Stanford, UCSF, UC Davis, each of us have a dedicated program, and we work together, right? So we're collaborative. So this is a wonderful environment to live in if you have PSC. If you have to be somewhere, right?
I'll remember
that. Remember that, Tom? Okay. So my project, or my charge, is to talk about current and upcoming PSC therapies. I want to apologize. I did not put in a disclosure slide here. I normally do, but just for transparency, I do consult for a lot of the pharma industry, and my institution does get funds to do these clinical trials, so just being transparent. So what are the key points I want to touch on? First, what do we want from our treatment? Seems like a pretty basic question, right? We want a cure for PSC, but let's be a little more specific about that. Second question is, how are we going to know if a treatment actually works? What are the criteria? What do we want it to do? And third question, I think Dr. Yamam already told us, there's not really anything that really works yet, but does anything work? And where are we now? So main talk update of where we are with trials right now. Excuse me. So before I get too into this, let's think about what we talk about, what we mean when we talk about treatments and therapies. We often just think about drugs, right? Medications. There are new drugs. They're haven't been approved for any therapy. There are new drugs looking for new indication. That would be elafibranor, for example. Old drugs looking for off-label indications, so things like ursodiol, oral vancomycin. Those are already approved. They're out there. They're generics. So medications, but we also think about procedures, you know, ERCP. There's different ideas on how frequently ERCP should be done. Could they be done routinely and keep these bile ducts open? There's a little data on that, but you know, that's sort of uninvestigated. And then there's non-medical therapies, diet, supplements, behavioral therapies. So all these we have to think about. These are all therapies for PSC, and they address different aspects of PSC. But down at the bottom, ideally, we want the level of evidence of safety and efficacy for any of these interventions to be the same. We want to have a high bar to demonstrate that a therapy is both effective and safe. Now, in reality, that's harder said than done. You know, for new drugs, there's a financial incentive, and the bar is very high for the FDA to get those things approved. And so the level of evidence for both effectiveness and safety is going to be very high. We're talking about, you know, diet. There's no one's going to approve that, but we still want to have good evidence that if you're going to change your diet, you're going to take a supplement, that there's evidence that it's effective. Safety is probably not much of an issue. But I also say with old drugs, if we're going to advocate their use, we need to know that they're effective and safe before we start telling people they should be taking these. So what do we want from a treatment? And this seems kind of straightforward, but I think it's very helpful to break it down. And this is what the FDA says. And I honestly think, while we argue with the FDA quite a bit about what we have to do to prove this, what their charge is, what their mandate is that a therapy should have a positive, clinically meaningful effect. And what they mean by that is that the positive effect should be on how an individual feels, functions, or survives. So if something doesn't make you feel better, function better, or live longer, if it just makes your liver test better, it really isn't, that's not a positive, clinically meaningful effect. I don't think anyone here would be that happy if, you know, all the drug did was make your liver test better. So now what do we actually want from these therapies? And we can put them in two different categories, and I think this is important to understand, especially when we talk about new therapies that are coming out, and I think we might have a couple of examples to be discussed later. So from a physician side, we often focus on survival. How can we prevent this disease from progressing to needing a liver transplant? I think it's important to patients also, but sometimes we also miss the other part of the equation, which is how can we make patients feel better? Even if it doesn't prevent the progression to cirrhosis and need for liver transplantation, patients still suffer from lots of symptoms, from abdominal pain, fatigue, pruritus or itching, sleep disturbances, all sorts of things. So are there other interventions we can do that just address the way people feel? And how do we know if these things work? Well, if we are able to show that patients survive longer or have less complications, that is, progression to cirrhosis, the complications, need for liver transplantation, et cetera, we need to show that a therapy prevents those complications compared to a placebo. So that means a randomized controlled trial where some patients get placebo, some patients get therapy, and neither the patient nor the investigator or anyone else involved in the study knows who gets what, and at the end of the study you look and see, did it work? Now, these sorts of studies to actually prove that, because PSC is a very chronic, long-term disease, takes many years. And this has been a major barrier to why we don't have therapies. Even at studies that last 5 years, because those events actually are relatively rare and infrequent in most patients, we don't have a lot of these events. In terms of telling whether a therapy makes someone feel or function better, it's a little bit more straightforward in that we can use how a patient reports their feeling, these patient-reported outcomes, and Donna Yvonne's going to talk about this a bit, and it's working very hard to have a very specific test that we can use, or instrument we can use, that's PSC-specific, so that we can actually measure some of the effects of these therapies that make patients, how patients feel, and if there's an improvement there. And then the last piece here I want to just mention is what we're lacking, and Dr. Yimam alluded to this, is a biomarker that's used in a lot of other chronic diseases that take a long time to develop complications. So if you think about diabetes, you have your hemoglobin A1C, you think about hyperlipidemia, you have your cholesterol. You know, if you lower those things, then that's assumed to prevent the clinical outcome that would take years to observe. So if you improve those biomarkers, we feel relatively confident, reasonably confident, that that is going to have a meaningful effect. The problem is if you don't have that biomarker that you're confident in, you could change the biomarker but not be measuring either beneficial effects or, more importantly, harmful effects. And there's lots of examples of where drugs kind of made the biomarker better, but the outcomes actually were worse. An example of that is high-dose urso. So there's a study of high-dose urso, right? Liver tests get better, but at the end, when they looked at the data, the people that got urso actually did worse than the people that got placebo. Now that's at the high dose. That's not been seen at the regular doses, so only applies to the high dose, but it's an important lesson that alkaline phosphatase isn't a very good biomarker for us in this disease. So what about current therapies? Does urso work? Well, there have been lots of studies at it at different doses, large trials, both in the United States, Europe, largest one in Scandinavia. It didn't work. If you look at those lines, you can see they look very similar. One group got URSO, one got placebo, and that's how many patients were surviving over time, and they look the same. There's no difference. Now, if you do have a drop in your alkaline phosphatase with URSO, you do better. So if you look at the top lines, those are patients that had improvement in their alkaline phosphatase, and the lines that dropped more steeply are those that did not. So they progress more rapidly. But there's 2 lines in each group, and 1 line in each group is with URSO, and 1 line with each group is placebo. So regardless of whether you got URSO or placebo, if your alk phos got better, you did better. So it's not necessarily the effect of the URSO, it's just the improvement in the alk phos. So again, the data on URSO is not great. It's safe at the doses we use. Some people might get a benefit. There's sort of conflicting data there. My practice is to offer it to patients if they want to take it. Some people want to take it and do it. Others are like, no thanks. They don't want to take medication, and that's fine. The more controversial topic is oral vancomycin, and I have to be careful here. I don't get myself into trouble again. No, I think that the data on oral vancomycin is somewhat limited in terms of its effect on liver disease. I have this asterisk at the top. The data on oral vancomycin and the colitis associated with PSC is really pretty strong. I wouldn't say it's great, but it's increasingly consistently showing that there are patients with IBD associated with PSC, which is sort of a unique type of IBD. They don't respond to other biologics, and they get on oral vancomycin, and their IBD gets so much better. And there's a very nice open label study from Birmingham in the United Kingdom that showed this very dramatically. So I think for the IBD, that's one story. I think we still have questions about safety of long-term oral vancomycin use. That's not been well studied, but I think that's a separate issue. The question about whether oral vancomycin works for the liver remains unanswered, and we need more data on that to really say, yes, it works or it doesn't. So where are the current therapies in terms of targeting the PSC as a disease? And as Dr. Mum was mentioning earlier, we really don't understand the pathophysiology, what causes PSC. And I would say more importantly, not what causes PSC, but what causes PSC to progress. We get caught up in this, what causes PSC, but once you got PSC, it doesn't matter. This is not a disease we're going to prevent. And the things that cause PSC may be quite different than things that cause PSC to progress. So I think that's a key point. So a lot of people like to focus on gut inflammation, but all the data we have so far really doesn't link gut inflammation with disease progression in PSC. And so I think that looking at targeting gut inflammation itself is not really where the money's going to be. There may be things about the dysbiosis, the alterations in the gut microbiome, the metabolites that are produced. There may be something there. And that's a potential area where diet and other therapies may interact. Liver inflammation is a focus. Obviously, there's inflammation of the liver associated with PSC. Liver fibrosis is a target. And then bile duct injury, the cholestasis, the slowing of the bile flow causes further injury. So if we can do things there, and that's where we have the most tools really, is working on the cholestasis part. So if we now look at where are we currently, just to go over some of the most recent data. This is the first really positive result of a phase 3 study to date, and this was performed only in Europe. It's a drug called Nor-Urso, or now they're calling it noracolic acid. It was a NUC-5 study, and its design was a bit interesting. So patients were randomized to receive either the drug or placebo. 2 patients got drug for every 1 that got placebo. And then after 96 weeks, they did a second liver biopsy. So they had liver biopsy at the start, liver biopsy after 96 weeks, 2 years. And the endpoint, what they were looking to see is, did their alkaline phosphatase drop below 1.5 times the upper limit of normal? And did they have no worsening of the fibrosis in their liver biopsy? Now, if you think about Dr. Yamam's patient who did not get this drug, they went from stage 3 to stage 2 with no treatment. So you have a certain amount of noise already in your liver biopsies just based on what we know. The other thing I will say about this is that no worsening, but there were patients with stage 4. So if you're at stage 4, you can't get any worse. So all you had to do was drop the alk-phos. So this is not really a study that's telling us that people are surviving longer. It's giving a hint maybe, but I have a little issue with the endpoints they had. So anyway, it was a relatively large study. The drug works kind of like urso, but has some additional properties that may protect the bile ducts more. And they did have a positive result. You see that over on the left, that's their primary endpoint. That is their alkaline phosphatase less than 1.5 times the upper limit of normal and no worsening of fibrosis. And you see 15% that got the drug had that, compared to 4% in the other group. So not a big effect, but better than nothing. And if you look at the changes in the fibrosis stages, you see that about half the patients with placebo were unchanged and 40% worsened, and only 20% on the noracolic acid had worsening, and more than half remained unchanged, and a quarter improved. So, looks a little better, like the fibrosis is improving. Now, when you look at other markers of fibrosis from this study, we didn't see any effect. So some of the things like FibroScan, no change. If you look at the ELF score, the Enhanced Liver Fibrosis Score, which is a blood test we use to look for changes in fibrogenesis, the production of fibrosis, no change. And we would have expected those to change to some degree in these. So not supported that. So nor-urso, promising, good result, but still unknown, I think, in terms of the strength of its evidence. And we'll see where this is going to go. The other drugs and therapies that are in trials right now are in phase 2. Elafibranor, I'm going to just go over this briefly. Ben from Ipsen is going to talk about this in his segment in terms of where it's going from here. But this was a phase 2 study. It improved alkaline phosphatase. So the gray bar are the patients that got placebo. After 12 weeks, they then got the drug, and you see their alkaline phosphatase improved. The light blue is a lower dose of elafibranor. The dark blue is the higher dose of elafibranor. So alkaline phosphatase improves. Great. We pretty much figured it would. What about other markers? And this is where we want to see changes. So if you look at the ELF test here, you can see on the left-hand side a little bit of an increase in those that got placebo. And this is an interesting thing. We've seen this in other trials, that even in just 12 weeks, that ELF test tends to go up a little bit in the placebo group. And then if you look at the higher dose, it remains stable. That LSM, that's FibroScan, that's a liver stiffness measurement. So FibroScan remains stable in the higher dose, whereas it increased a little bit in the other groups. And Pro-C3 is another fibrosis marker, and it dropped a little bit. Especially, so the higher dose looks pretty good in terms of preventing the fibrosis, at least on these biomarkers. And this again just shows patients that switched from the placebo to the treatment also had that reduction in the ELF test. So again, another signal that there's actually something maybe going on here. The other drug that had some positive phase 2 results was this monoclonal antibody. So this is an infusion. It's not a pill. And it targets this chemokine called CCL24, which is involved in the recruitment of immune cells, especially to the liver. I'm not going to go over this, but it's targeting both fibrosis and inflammation. And patients got 1 of 2 doses or placebo over a short period of time. No real changes in liver tests, I would say. I mean, they're all over the place. And this is not a drug we'd really expect to have those big changes in liver tests. But it did show some promising effects in terms of those fibrosis markers. So the ELF test here tends to remain stable while it went up in the placebo group. Same with liver stiffness, went up a little bit in the placebo group and remained stable, went down a little bit in the treated group. So some promising results there. This drug, though, is, they've had discussions with the FDA to move to phase 3. Still waiting to find out if they'll ever be able to move it forward. And now if you look at what's actually listed in clinicaltrials.gov for PSC and intervention, this is something you all can do yourselves. This is a publicly available database of clinical trials, and you just type in primary sclerosing cholangitis, you'll get everything. If you only want to look at those that actually are an intervention, you can filter it for that, and you can look for those that are only openly recruiting right now, and they'll list that, and they'll have contact information, a center if it's close to you, or if you just want to find out more about it, where to go. And these are the ones that are currently open, and I just want to highlight a few into a few different groups. So there's a lot of interest in microbiome. There's a trial going on now with a microbe, this LBP8, from a Korean company. This bacteria is found in fermented foods, kimchi and others, and it has some certain properties in terms of metabolites it produces. I don't think we really know which it produces, but it's had some positive effects. And in a mouse model of PSC, it has some really interesting effects in terms of preventing the disease markers. And when healthy individuals take this bacteria, it doesn't stay in the gut. It's not a normal gut microbe, so it only lasts for about a week, and then it's undetectable. And so in this study, patients are getting treated up to 24 weeks. The outcome is just to look at alkaline phosphatase changes. So alkaline phosphatase at entry has to be greater than 1.5 times the upper limit of normal. But interesting sort of approach to this therapy with microbial therapy. There's a few different types of sort of microbial transplant or other more kind of poorly defined microbial communities, I guess. University of Minnesota has a study open using an oral capsulation of donor microbiota, and then there's some fecal microbiota transfer experiment trials, one in France and one in Birmingham, UK, so I don't know if you want to travel, but they're there. There's a study out of Boston, Josh Korzenick's running, using the concept of detoxification of sulfur, which he has data suggesting that may be driving the disease. He's done studies with diet that you might be aware of, and a low sulfur diet. And this is another way of approaching this. This is using high doses of hydroxycobalamin, which is essentially vitamin B12. But instead of doses that we typically use for treating pernicious anemia, this is actually using doses that are used for cyanide toxicity. So it's a higher dose, but it's FDA approved, safe. And so it's a short study right now. It's sort of everybody gets placebo, everybody gets drug. You just don't know which you're getting at the time. There's an IV dose and then oral drugs. And this is a nice study in that you don't have to come into the clinical trials unit. They have a nurse come out to your house and take care of all that. So very convenient for patients, especially if you're not close to a clinical trial center. And then oral vancomycin, there's a couple of studies going on there. The largest one in Italy at the University of Milano Bicocca, using 2 different doses of vancomycin versus placebo, and then one in Canada. And the one in Italy has done fairly well recruiting, and so that's going to be very interesting to see some results from that, and hopefully not too distant future. And then really in early stages, there's a small interfering RNA. This is a different approach to try to knock down the expression of genes, and this is looking specifically at trying to knock down a gene that's involved in the production of bile acids. So some drugs kind of target it indirectly by inhibiting signaling to those genes. This one just knocks the gene down, so reduces the bile acid. So that's in early development, and then using a statin drug, rosuvastatin at Stanford, is going on. It's just a very short trial to look at what are the changes. There's a larger study of this going on in Sweden currently, And so that's one we'll also be looking for to see what the results are. And I can say there are lots more to come. There's a lot of interest in PSC, and so I think you'll see additional early phase 2 studies coming out in the coming year. So there's still a lot of promise out here. We still have a high bar to get over. I'm very hopeful, given that we're going to see this phase 3 study of elafibranor launching soon, and I think that's going to be a major milestone for the PSC community to see if we can get that over the hurdle with real clinical outcomes to show that a drug actually improves how patients, survive, which is really the key. And we also, I should mention also, we have drugs in the pipeline looking for how patients feel. So addressing symptoms is also important. I think we've got a lot of positivity here. So thank you very much for your time.